Great. So I assume that you all can share you can see the PowerPoint at this point. If you can't, I suppose typing something into the chat would be the way to go. So I'm going to talk about abortion policy in 2020 from a public health perspective and give you some information about what I think public health professionals need to know, and then offer some suggestions about what I think public health professionals should be doing. My hope is that by the end of this webinar, you will be able to describe key trends and likely events in abortion policy in 2020, describe the evidence base relevant to current abortion policies, articulate what it means to engage with abortion from a public health perspective, and to identify at least 2 activities that public health professionals can do to bring a more professional approach to abortion-related work in our field. As I've alluded to, my hope as part of both this conversation and a larger body of work that I'm engaged in is that we can begin to articulate what it means to engage in abortion-related work as public health professionals from our professional identity. Most people in public health, when they come to doing work on abortion, are coming at it from a place of their personal beliefs or passions, regardless of where they are on the political spectrum. And my hope, even just by raising this, is that you'll take a moment and notice what your own views are on abortion, whether they're political views, personal views, and just notice them and begin to push yourself to think about and begin to articulate what it means to engage on the topic of abortion from a professional perspective. What I'm asking you to do may make you uncomfortable, since it's really different from how people in public health are accustomed to talking about abortion, and people in general are accustomed to talking about abortion. So I invite you to make yourself uncomfortable. Typically, when we talk about abortion, we talk about it as a political issue, as I mentioned, whether someone's pro-choice or anti-abortion or pro-life, or what the politics are going to be in terms of an election and how that's going to play out in terms of voting and different party platforms. People talk about it as a personal issue, and people have their own experiences, either making a decision to not have an abortion or to have an abortion, or have somebody in their life who has made that decision when faced with an unintended or unwanted pregnancy. People talk about it as a moral issue, a legal issue in terms of what's going on with the courts, and a healthcare issue sometimes. I will, over the course of the presentation today, provide some ideas of how we can talk about it from a public health perspective and really begin to develop our language as a field and as a profession to talk about abortion as a public health issue and from a public health perspective. So I'm going to dive in and give a little bit of a basic backgrounder on abortion policy and relevant research in 2020. To start, it's really important that we all know that abortion is currently legal in the United States. So even though there is news coverage about possible changes in abortion policies or coverage of policies that say abortion is illegal or going to be criminalized, none of those are currently in effect in the United States. The laws, the Supreme Court decision that makes that true is Roe versus Wade. And for people who don't know, Roe versus Wade was decided in January 1973. And what that decision did was it made abortion legal throughout the United States. So it said that states could not make abortion illegal in their own states. So there had been some states where abortion was legal prior to Roe, the Roe decision. And what Roe did was make abortion legal throughout the United States. So even in the conversations that happen now about the possibility of Roe versus Wade being overturned, that would not make abortion illegal throughout the United States. It would just return the decision back to individual states. Soon after Roe versus Wade was decided, the Institute of Medicine, now known as the National Academy of Sciences, Engineering, and Medicine, released a report on legalized abortion and public health. Some of the things that they concluded based on their review of available information at the time was that many women have abortions regardless of whether it is legal, that maternal morbidity and mortality are greater with illegal than legal abortion, and facilitating women's ability to obtain abortions earlier in pregnancy can help reduce morbidity and mortality due to abortion. The findings in that report, as well as other research that happened both then and over time, led to essentially what has been the prime way that people in public health have talked about abortion, which is that legal abortion is one of the greatest public health triumphs of our generation. And if you do a Google search for public health and abortion, you'll see slogans like this come up everywhere. To make it explicit for people who aren't picking up on this and who aren't as enmeshed in this as I am, what you'll see in the middle of this slide is a coat hanger, which is a way of alluding to how people have in the past attempted to self-induce their own abortions in an unsafe way. And so the idea is that by having abortion legal, that reduces people having unsafe abortions, which is why it's important for public health. As I'll talk about a little bit later, the distinction between legal and safe, or illegal and unsafe, the distinction between illegal and unsafe is not the same now as it was in the 1970s. It's really important to note, though, that especially in the US, it's not just a question of legality in terms of abortion. There are multiple state policies that restrict abortion in the US. Many of these policies or laws have been in place in some states for close to 40 years. Most states restrict the use of public funding to pay for abortion for low-income people. Most states require parental involvement in a minor's decision to have an abortion. And more than half of states have laws that require people to wait a specified amount of time between getting information about an abortion and having an abortion, sometimes involving making 2 trips to a clinic. And people sometimes have to wait between 24, 48, and sometimes 72 hours. Again, it's not just a question of legality. There's a limited number of abortion clinics available in some parts of the US. This map here maps the distance between where people live and the nearest abortion clinic in the US. The parts of the map that are red are the places where people live more than 100 miles from the nearest abortion clinic. And the places in blue are where people live closer. So you can see that in huge swaths of the country, a notable number of people live more than 100 miles from the nearest abortion clinic. For a long time, that was the conversation, that there were those types of restrictive abortion policies, limits on public funding, parental involvement laws, waiting periods, and then multiple counties that did not have an abortion provider. But since 2010, so over the past decade, things have gone really topsy-turvy. And there's been a dramatic change in the abortion policy landscape in the United States. Between 2011 and 2016, there was a dramatic increase in the number of state-level restrictive abortion policies. The 334 restrictive abortion policies enacted between 2011 and 2016 accounted for 30% of all the restrictive abortion policies enacted since Roe versus Wade. In that time period, we also saw a number of other changes where policies that existed got lengthened and strengthened. So waiting periods grew from 24 to 48 hours or 72 hours. Parental notification laws became parental consent laws. We also saw a change in the type of policies, and I'll talk a little bit more about them in a moment. We also saw changes in the number of policies that were in place in states at the same time. So when we think about restrictive state abortion policies. Some of what I'll show you over the next few slides are some of the newer types of policies that we see. And we typically classify them into two different categories. There are the policies that have the stated purpose of improving women's health and safety. So things like requiring abortion providers to have hospital admitting privileges. So abortion providers who are providing abortions in freestanding clinics to have admitting privileges at a nearby hospital. Requirements that all abortion facilities meet the standards of ambulatory surgery centers, which are freestanding facilities that provide or perform surgeries that require outpatient surgeries and procedures that require a much more intensive level of staffing or have a separate operating room. And then policies that require medication abortion to be provided according to the originally approved FDA protocol, as opposed to evidence-based changes in the way that medication abortion is provided. And then we have policies that have the stated purpose of changing people's minds about having an abortion. So things like mandatory waiting periods, mandatory ultrasound viewing requirements, and ultrasound is a typical part of an abortion, but there's laws that require people to view the ultrasound. And then there's mandatory counseling requirements. In terms of what the research evidence says, there's no evidence that there is a public health problem or that the types of policies that have the stated purpose of improving women's health and safety actually do so. Research is very clear that abortion is safe. This is not just me saying so. The National Academy of Sciences, Engineering, and Medicine, the new name for the IOM, concluded this, that in fact, more than 99% of all abortions provided result in no major complications. And there's no evidence that policies that have the stated purpose of improving women's health and safety actually do so. There's also no evidence that a significant proportion of people presenting for abortion care are uncertain about their decision or that such policies change people's minds. We know that most women are certain about their abortion decision by the time they present for abortion care. And in fact, they're more certain than people who are presenting for knee surgery, who are making a decision about mastectomy after a breast cancer diagnosis. And we also know that policies that target women's decisions do very little to change people's minds about their decision to have an abortion. From a public health perspective, and I can't state this piece clearly enough, what the National Academy of Sciences, Engineering, and Medicine concluded in their 2018 report is that restrictive abortion policies are not based in scientific evidence, that legal abortions in the United States are safe, and that it's actually the state abortion policies, things like waiting periods, for example, that really, as well as hospital admitting privileges laws, it is these types of laws that actually negatively impact the quality of abortion care in the United States. When we look a little bit about what that research is, in terms of the impact of these restrictive policies. So before I look down the side of, is there evidence to say that they're needed in relation to people's certainty or in relation to safety? And now here I'm talking about what's the impact on people in terms of the policies. So we know that abortion policies lead women to face multiple financial and logistical difficulties to obtain abortions. Most women are able to overcome the logistical and financial difficulties, but some are not. From a public health perspective, it's important to note that many restrictive abortion policies are implemented through the health department infrastructure, and that health department commissioners, in some cases, are defending non-evidence-based restrictive abortion policies in court. That was the case in the Whole Woman's Health versus Hellerstedt, Supreme Court case that was decided in 2016 that was about a Texas law requiring abortion providers to have hospital admitting privileges, requiring abortion facilities to meet the standards of ambulatory surgery centers. It is the case again now with the Supreme Court case, June Medical Services versus Rousseau, which considers a Louisiana law requiring abortion providers to have hospital admitting privileges. And I'll talk more about that case in a few moments. So we've done some research about how state health departments engage with abortion. What we found through reviewing all of the websites of state health departments in the US about for all the instances in which abortion came up is that state health departments typically do what's required by law and focus on law enforcement activities. That can be enforcing facility regulations, so regulating abortion facilities, as well as enforcing things that they call women's right to know laws, which sometimes include scientific evidence related to abortion, but often are based on non-accurate information. Local health departments also sometimes engage with abortion. There are many similarities to how state health departments engage, although fewer of them do seem to engage with abortion than state health departments. But when they do, there's more evidence that they engage in activities to educate and facilitate access to abortion that are not mandated by law. We've also done some research to do some in-depth interviews with people who work in health departments to understand how they engage with abortion. So typically we've talked with people in maternal child health and family planning. And some of what we found echoes what we found through our website research. We found that people often are executing or implementing legally mandated activities as prescribed and initiating public health approaches to abortion without a mandate. So things like facilitating access to abortion by including information about where abortion providers are in the county on their website. We also found a few instances of people bringing a public health approach to mandated activities. So things like when required to implement a women's right to know law, making sure that all the information included in those materials was based in the best available scientific evidence. And I'm happy to talk more about those examples if people are interested. I now want to circle back to June Medical Services versus Rousseau. As I mentioned, this is a current Supreme Court case considering a challenge to Louisiana's law that requires abortion providers to have hospital admitting privileges. As I mentioned earlier, there's no research evidence that admitting privileges make abortion safer or are needed. There are currently 3 clinics in Louisiana that provide abortions, and the law could lead 2 of the remaining 3 clinics to close. If that law goes into effect, the majority of Louisiana women of reproductive age would live more than 150 miles from the nearest abortion clinic. There's a question of whether the court will overturn the Whole Women's Health versus Hellerstedt decision from 2016, which if they did that, that would allow not only the Louisiana law to go into effect, but depending on how the court wrote their decision, it could allow other states to allow similar laws to go into effect. The decision is expected in June 2020, and for those who are interested in following along, the oral arguments in the case will happen next week. One of the things that could happen if the law goes into effect is that fewer people in Louisiana will be able to obtain an abortion. That is some of what happened when the Texas law went into effect. And if that happens, we actually have some really high quality research evidence about what the health impacts of that will be. From a study led by my colleague, Dr. Diana Green Foster, also at ANSIRH UCSF, a study called the Turnaway Study that recruited about 1,000 people presenting for abortion care throughout the US and used a quasi-experimental design to look at the impact of either receiving an abortion or being denied an abortion, and following people over 5 years. What this research has found is that being denied an abortion leads to pregnancy complications, decreased physical health over 5 years, increased financial insecurity, continued substance use in pregnancies carried to term, continued violence from the man involved in the pregnancy, and decreased ability to take care of children. So to summarize this, being denied an abortion has adverse impacts on women's physical health, on their continued exposure to violence, and adversely impacts their ability to take care of children in comparison to people who are able to obtain a wanted abortion. Another way of thinking about some of the public health impacts is from another study, and I apologize for not having the citation on here, another study led by my colleague, Dr. Nancy Berglass, also UC Berkeley DrPH graduate. For this study, we recruited people in prenatal care in southern Louisiana and asked them about their pregnancy intentions, whether they had considered abortion for this pregnancy, and whether they faced what we call a policy-related barrier to abortion, and asked what their health and social service needs are moving forward. We found that people who had considered abortion tended to have higher needs for food stamps, home visits, mental health services, pregnancy options counseling, substance use disorder treatment, and people who were unable to obtain an abortion due to a policy were more interested in pregnancy options counseling, substance use disorder treatment, and counseling and shelter for intimate partner violence, all consistent with findings from the Turnaway study. So the sample size on the policy-related barrier is actually pretty small, and so if you look at the raw percentages, there's some suggestion that there's other patterns that would be also consistent with the Turnaway study findings. And these suggest that in places where there may be a policy change that goes into effect that decreases people's ability to obtain abortions and leads more people to continue unwanted pregnancies, that public health practitioners and healthcare providers may be caring for people who have more needs than what they are accustomed to navigating. So I want to take a moment and sort of raise again, sort of re-raise a heightened sense that things are about to go topsy-turvy again. So I've been giving versions of this talk for a while, and what you heard was pretty similar to what I have been giving for probably 7 or 8 years. As of about a year and a half ago, things have been changing dramatically again. When Justice Kennedy stepped down from the court, Justice Kennedy had been a swing vote in terms of abortion cases. He was replaced by Brett Kavanaugh. And there is a change in the makeup of the court, and people who pay attention expect there to be a change in the way the court is making decisions on abortion policy moving forward. In part, in response to this and the potential or the thought that it's possible that Roe versus Wade could be overturned, a number of states have introduced 6-week abortion bans, or what they call heartbeat bans. This is now not quite up to date, but these are sort of where things are in terms of these bans. The red and orange colors are the essential outright abortion bans, or the 6 to 8 week bans. These are designed to be a challenge to Roe versus Wade, to get the Supreme Court to reconsider that decision. It's important to note that Roe being overturned would not make abortion illegal throughout the United States. It would allow states to implement their own policies regarding the legality of abortion. If Roe versus Wade were overturned, colleagues have done some estimates of where we would see changes in the number of legal abortions. So the darkest purple are the places where we would expect the number of legal abortions to decrease the most. And you can see that there's significant swaths around sort of Louisiana, Texas, Alabama area, as well as up through the Midwest, where you would expect to see the biggest decrease in legal abortions. And that's because of the patterns of where these state laws that would recriminalize abortion are. And so that's where people would have the farthest to travel in order to obtain a legal abortion. This June Medical Services versus Rousseau case that I mentioned before is one of the avenues that people think could lead to a dramatic change in abortion policy. In addition to considering whether the Louisiana's hospital admitting privileges requirement is constitutional, there's also a component of the case that has to do with whether abortion providers can bring cases on behalf of their patients, which is something that they've been allowed to do since the 1970s. To spell it out, if the admitting privileges law went into effect in Louisiana and other states were allowed to also implement such a law based on the decision, that could dramatically reduce the number of abortion providers throughout the United States. So it wouldn't be a direct overturn of Roe versus Wade, but it could lead to a dramatic change in the availability of abortion throughout the United States. And if the court ruled that abortion providers can no longer bring cases on behalf of their patients, that could also make it next to impossible to challenge restrictive abortion policies, and that would then allow them to go into effect. I think what's really, really, really important to note from a public health perspective is that these old public health slogans do not necessarily apply anymore. So the idea that illegal abortion is unsafe is not based in what's going on now. There now exists medications for medication abortion, so mifepristone and misoprostol, that are used for, that are provided as part of clinical care for abortion patients to manage an abortion. In many other countries, people use these pills on their own to self-manage their own abortions, and people can do that safely. And there's some evidence that that is already going on in parts of the US as well, in places where abortion is less accessible. People using misoprostol alone to do that, that can be effective in about 85% of cases. The concern, it has to do with people using other unsafe means of self-inducing an abortion, but also a concern that people will be criminalized and punished for self-inducing or self-managing their own abortion, which has already happened in some states in the United States. So shifting gears now, I want to talk a little bit about what it means to engage with the topic of abortion from a public health professional perspective. What I argue now, whenever I give versions of this talk, is that we have a big problem in terms of discussing abortion policy in the United States when we're making health and safety arguments or other health-related arguments, in that public health professional voices are typically absent from both scholarly and public conversations around how health departments should engage with abortion. I know that when I was in the School of Public Health, both at Cal and also when I did my master's degree in Michigan, that the only time abortion came up was when we talked about illegal abortion being unsafe in other countries, so in a global context. We never talked about domestic abortion policy. And so we didn't build the capacity for public health professional voices to be engaging on the topic. One of my large professional goals is to engage with other public health professionals in developing and describing how health departments should be engaging with abortion, but also how public health professionals should be engaging with abortion more broadly. I think one very clear way that I want to argue our role as public health professionals, or what our role is as public health professionals in engaging with the topic of abortion, is to always be posing the question about how do abortion laws affect women's and children's health? What is the evidence? What is the best research evidence that we have about that? What are the direct impacts? And then how does it impact the health and social service needs of people? And what are our responsibilities and obligations in terms of making sure that we have the capacity to meet those needs? So let's talk about this a little bit more. So how have public health professionals approached abortion in the 20th century? As I alluded to earlier, it's been a focus on legal abortion and saying that legal abortion is the only way for abortion to be safe. So saying that legal abortion keeps people from self-inducing their own abortions, and therefore it's one of the greatest public health triumphs. We've conflated thinking about public health approaches to abortion with Planned Parenthood. We associate Planned Parenthood with abortion. When people think about abortion, they think about Planned Parenthood. So we do from a public health perspective. We talk about all the unsafe abortions that take place each year worldwide. I don't want to diminish attention to them, take away attention from them. But I also want to just say that legality is not the only component of that. We've focused on it as a political issue in terms of protest. Here's my take on how I think public health professionals should approach abortion from our professional perspective in the 21st century. I think we need to advocate for abortion policies to be based on the best available research evidence, to focus on health outcomes of abortion-related policies and regulations, facilitate access to and ensure the availability of services, know the difference between unsafe and illegal abortion, and then use accepted public health frameworks, such as the 10 essential public health services, to guide our work. I've done some work trying to look at how we can use the 10 essential health services framework to guide our work on abortion. My assumption is that everybody on this call is familiar with this, but for the few people who might not be, the 10 essential health services framework provides a foundation for public health activities, describes public health at state, tribal, local, and territorial levels, and it's used as a foundation for the national public health performance standards, and it provides a structure for national voluntary public health accreditation. A few years ago, we published a paper describing what we called a 21st century public health approach to abortion. It's our vision for how public health professionals, particularly in health departments, can engage with abortion from accepted public health frameworks. And I'm going to spend the next few minutes walking through a few ideas that we threw out there. So using the first essential public health service of monitoring health status to identify community health problems, I'm going to just spell out the ones that are in green here. So apply principles for data collection for other vital statistics data collection to abortion data. For example, all data collected should serve a public health purpose, protect patient and provider privacy, and minimize the compliance burden on providers. In terms of informing, educating, and empowering people about health issues, developing health education strategies to inform women about state abortion laws, including how they might affect their experiences with obtaining or even their ability to obtain an abortion, and steps they can take to overcome these obstacles. Mobilize community partnerships to identify and solve health problems, so engaging stakeholders to successfully implement new abortion services, including medication abortion, second trimester abortion services, and later services when those services are otherwise unavailable. In terms of essential health service number 5, developing policies and plans that support individual and community health efforts. To promote the use of a scientific knowledge base in policy and decision-making about abortion, including but not limited to policies related to the safety of abortion and health outcomes from abortion. Ensure that the best available scientific evidence is considered in the process of developing regulations, standards, recommendations, and guidelines that apply to abortion provision. And conducting needs assessments about state and local healthcare systems' capacity to provide abortion care to all women who seek to obtain one. Number 8, assure a competent public health and personal healthcare workforce to plan and implement trainings for public health department health inspectors who inspect abortion facilities. In terms of number 9, evaluating the effectiveness, accessibility, and quality of a personal population-based health services. To evaluate barriers to abortion care in a state or county, including how policy changes affect women's ability to obtain abortion care and delays in obtaining abortion care. And then number 10, to conduct research to attain new insights and innovative solutions to health problems. So specifically to conduct research to identify strategies to mitigate the harms due to state laws regulating abortion. So what can public health professionals do? Here's some action steps, including for people who do not work in a health department, since, as we know from research, fewer and fewer public health graduates, graduates from schools of public health actually go to work in health departments, is that we can seek to increase and normalize the conversation around abortion in our organizations, our agencies, our schools, our classes. We can read and discuss the 21st Century Public Health Approach to Abortion paper and commentary that we published with public health colleagues. If it's in a health department, discuss actions your agency could take. Stay informed about evidence from the latest research about abortion. If people are interested, I'm happy to tell you some researchers to follow through some PubMed searches, or if you're interested in social media following, who you might follow on social media. And then I think you can, if you do follow research and researchers on social media, you can share research findings about abortion and abortion policy with colleagues and via social media. And so with that, I am going to close the more didactic portion of this and open this up to questions and conversation. I'm happy to respond to questions and then also to hear people's thoughts about roles and responsibilities as public health professionals in terms of engaging with abortion and what we can do to build a more professional approach to abortion in our field. So with that, I will stop the share and I will pull up my video, and then hopefully there's a way that I can take questions.
So there should be questions coming up on the chat, Sarah, if you see them. And if you want to read them out before answering them, that would be great.
That sounds great. So how do you see the presidential election affecting abortion law in the next 4 years specifically, apart from the naming of Supreme Court justices? I'm an expert on what the impacts of abortion policies are on people. And then I try and listen to and learn from people who are experts on predicting what's happening in terms of the policy. I can tell you some of the things that have been happening, and I would imagine that if we continue with the same administration, that these are likely to continue moving forward. So we've seen new Title X rules that people, place even more restrictions on use of Title X funding in terms of not allowing even basic options counseling about abortion in Title X clinics or clinics that take Title X money, and then having an even bigger wall in terms of not just a financial and administrative wall between taking Title X money and being able to provide abortion services, but also there's a physical space rule in relation to this. So you would expect more of that to continue. There's also, I mean, just last week, there were some federal policies that were introduced in the Senate about banning later abortions. I would imagine those would continue. And then I would, you know, on the other side of if there's a different administration, I think that the presidential candidates all have, or most of them have stated support for repealing the Hyde Amendment, which is what restricts federal Medicaid use in terms of paying for low-income people's abortions. And then different efforts to make medication abortion more accessible to people. So those are some of the things that we might see at play. And I'm happy to point you to resources, additional resources if you're interested. In terms of recommending engaging public health colleagues who may not see this as a public health issue, it's a great question. I'll tell you some of the things that we've tried. I would say I like to appeal to what we understand from the research evidence and to our shared identities as valuing the science. So I have, as a public health professional, I have very serious concerns about us basing what we say are public health policies on things that are not based in scientific evidence. So I would say a concern for the devaluation of science is a big piece of it. And then I would also say we know from research that denying people abortion has negative impacts on women's health and children's health. And so as public health professionals, we should be concerned about the negative impact that policies that are passed in the name of health and safety are having on the health and well-being of populations that we are supposed to be ensuring the health of. How do we ensure that abortion is not affected by presidential administrations? In other words, what's a more sustainable way to fight for abortion rights rather than always being on the defensive? So again, I'm not a political organizer in terms of abortion, so I can't talk about the sort of politics of it. I think that as public health professionals, we have a role of being, to a large extent, I mean, and actually let me step this back for a moment. Right now, we're thinking about this from a presidential standpoint, but even under the previous administration, the Obama administration, which was supportive of abortion rights and supportive of science, that was when we saw the dramatic increase in the number of restrictive state policies related to abortion. So that was all at the state level. And in terms of the policies that have, I would say, decimated abortion access throughout much of the country, those all went into effect when Obama was president. So I think, and a lot of those were enacted through state health departments and enforced through state health departments. So I think that having a more robust public health presence in terms of stating what the scientific evidence actually is related to these policies, and having a public health voice, either from within or outside of health departments, stating what the negative health impact will be of some of these policies is one way that we can take some action in terms of not being on the defensive, but being on the proactive standpoint of saying, this is what the impact of these policies are. And this is what policies that would actually be supportive of health would look like. Let's see. So what is your perspective on healthcare organizations offering abortion services as contracts with other healthcare organizations that do not offer abortions? For example, Dignity and UCSF. What are pros and cons to such a relationship? So I'm not speaking for myself. What I would say is that we know from available research that abortion is an essential health service for many people, and that making it so people are unable to obtain abortions can have negative health impacts. And so a public institution, any healthcare institution um, that follows the evidence and seeks to provide high quality care needs to make sure that the whole range of services that are necessary for people to protect their health is a part of that care. Lots of abortion research is not always accessible to non-researchers. How do we get the word out and make this research more engaging to those who don't read, get access to academic journals? So it's a great question. I will say on our website, on the ANSIRH website, we link to the research that we produce. Many of us try to publish in open access journals. And then we also create a number of infographics and issue briefs to be able to share more broadly. We also have a decent Twitter presence, and that's another way to be able to follow our research. And I would be happy to guide people through how to find things on our website. We're going through an overhaul hopefully in the next few months. But if you go to our website, ANSIRH.org, which is spelled ANSIRH.org, so Advancing New Standards in Reproductive Health, you can find our research. And if you email us for any article that you would like a copy of, we're happy to share those on a case-by-case basis for those that are not available through open access policies already. One roadblock that I've come across in the past is hearing that putting the science out there is in itself a form of advocacy, but after that, they don't do more advocacy after that because they don't want to be seen as political. What's your own experience with that line and encouraging people to engage with advocacy in addition to just putting the science out there? Yeah, that's an ongoing, that's an ongoing conversation that we have at ANSIRH as well. And I would say that we fall on a pretty wide range in terms of where people's comfort is in terms of being out there in the world. Where I personally land is that as a public health professional, my job is to advocate for policies based on the best available scientific evidence. And that is my job. My job is to make sure that, in the same way that clinicians are providing care in an evidence-based way, that as public health professionals, we're doing our job in the policy arena to make sure evidence. I see those as analogous. So I think as long as we are advocating for policies to be based in the best available evidence and saying what that evidence is, we are doing our job. And I would say that as we engage in more public ways, we get criticized more. I certainly, when I've published op-eds, I have certainly gotten hate mail and hate messages after that. And I think where I've personally landed in terms of my own comfort is that if I'm not out there, I get criticized by people. And if I'm out there, I get criticized by people. And so as long as I'm getting a balance of criticism on both ends, I'm walking a reasonable line in terms of advocating for policies to be based in evidence. Do you think public health professionals have a duty to be trained in advocacy or work with advocates? And have you seen great examples of advocacy work with public health professionals with relation to abortion? I think it depends on what your role is in public health. I would say our responsibility is to make sure that there are public health professionals who engage in advocacy. I don't think everybody does that in the same way that I don't do work in a wet lab, for example. So I think it's something that we need to assure exists as a field. I think as a scientist and a researcher, I think it's really important for me to work with advocates, in part because because I want policies to be based in the evidence. And so advocates are often the ones who are able to translate, even better translate, our findings to the policy arena than I am. But also so that when advocates are making claims that are not evidence-based, that I can say, wow, what you're saying right now really isn't based in the best available research evidence, and that we can have that dialogue. Um, I would say in terms of examples, I've had some good examples with advocates, both in terms of ensuring that my research findings are included in some of the advocacy, um, in a number of places where policies are being considered, or even in court, where my people are using my work in addressing evidence-related questions related to policy or in litigation. But also I've had examples where advocates were saying things that were not based in the available evidence. And I had conversations with them about it, and we had open and respectful dialogue about it. And many of them have shifted the way that they talk about some of the issues to be more evidence-based. So I think that there's, I would say that the key ingredient there is respect. The key ingredients are respect, and then being aware of what our roles are versus what advocates' roles are. And my obligation is to the evidence and to protecting people's health and well-being, and to making sure that I'm really clear on that in the conversations, and not getting pulled away from that.
That's great. Thank you, Sarah. This is Narissa again. Unless anyone else has other questions, we're almost at the top of the hour. I wanted to ask you whether you had any sort of last final words or things that you wanted to say.
There were two other questions that I think came in directly to me. So let me.
Oh, great. Wonderful.
So
Great. We have some more time.
Yeah. And one of them is a name that I recognize. Hi, Jim. It's nice to hear you again, or come in contact with you again. As a child abuse pediatrician, I add the increased risk of abuse and neglect to the morbidity and mortality of the undesired pregnancy. In this time of increasing awareness of ACEs, including the CDC, how is decreasing access to safe abortion justified? I share your question. So yeah, I mean, we see, I share your question. And I think that having more pediatricians speak, I think, is important. And then your second question of, is there evidence that septic or unsafe abortion is happening in the US, in the states with less access to abortion? I don't think we have evidence of that yet. And I think that some of it is that the methods for inducing one's own abortion are now much safer than they were before. So people are able to get misoprostol and mifepristone through the mail, and that, you know, in comparison to people self-inducing their own abortion with a hanger or something along those lines. So I think that's a possibility, and we need to be thinking about how we track that. Let's see. And then I think I'm at time. So there was one final question, and I'll try and answer that really quickly, and then I will sign off, which is, sorry if you talked about this when I stepped away for a moment. It seems the folks who work within health departments are often bound to the policies promoted by the Board of Supervisors and can only make public statements that are approved by federal agencies governing that area. So yeah, I mean, there are limitations on what you can say, I mean, when you work for a health department, and what you're allowed to say about specific policies. And I think every public health agency is likely to be different in terms of what exactly you're allowed to say. I think that there is often a role for people in health departments to communicate what the science says about what the likely impact of a policy is. I mean, that happens in terms of tobacco regulations. And so if we think of abortion policy like a tobacco, in the same way that we think about a tobacco regulation, yes, there's a lot of layers of approval that one would have to get to be able to say something. But I think being able to communicate about what the anticipated health impact would be is well within the scope of a health department responsibility. And then, so education along those lines, translating the research evidence. And then I would also say, going back to this piece around anticipating what the health and social service needs are going to be, is something that I think is absolutely essential in terms of talking within health departments of anticipating what are the additional services that people might need if the law goes into effect. So with that, I'm going to sign off. I'm very happy if people want to contact me via email at sarah.roberts@ucsf.edu. And thank you, everyone.
Thank you so much, Sarah, on behalf of the Public Health Alumni Association Board of Directors for your time. And thank you also so much to everyone who attended and all of your thoughtful questions. All right.
Okay, bye-bye.
Bye, thank you.